fluid is important. uh, what are the normal norms regarding it, and what are the abnormalities which we can encounter, and what are the effects of that abnormalities or the deviation from that norms, which can lead to different problems or disorders for the fetus and for the mother. These we are going to evaluate again, and I hope as you have already have an previous knowledge about these as well, because these are your revision lectures, you will be able to encompass more of the things, and anything deficient before which had been not been clear in your views, inshallah it would be rectified again. I hope so, inshallah. So whenever we are considering about the amniotic fluid, the important thing, as I told you before, that regarding its origin, its values in different gestations, its and the disorders related to its any abnormality regarding to it, is certainly going to help us. And also in this lecture, apart from the theoretical or the textbook knowledge which you have gained, and you have specifically learned about the norms and the deviations from the norms which we are going to discuss here. In addition to this, I am also going to emphasize you the clinical implications of the amniotic fluid, which we discuss in our textbooks regarding different topics which are available. Let's see what the amniotic fluid has a role in it. Similarly, eclampsia or hypertensive disorders, let's see what the amniotic fluid has to do with it. Or when we are discussing about the prom, so what are the implications? Although they seem to be a different topic, let's see how we are incorporating the amniotic fluid in all these scenarios and in all these pathologies which we encounter in obstetrics. So let's start about it. So we are going to discuss about the origin of the amniotic fluid, what are the physical features, what are the components, what are the main functions of the amniotic fluid, how is the clinical relevance, as I have told you before, what are the major two dimensions we are going to discuss about the oligohydramnios. As the name indicates, oligo means less, hydramnios means water. So lesser amount of the amniotic fluid, and on the other hand about the polyhydramnios. How we are going to define them? What are the possible etiological factors? What I would like to say is the possible etiological factors. How we are going to diagnose them, and what are the treatment um, options which are available to us, and what are the complications which we can encounter if we come across with these abnormalities. So this would be an outline for us for this our lecture which we are going to discuss today. So you see, this is the origin I would like to discuss. So with this picture which we come across, before you just see their labeling, let's see about the picture first. It's a fetus, definitely it's a fetus in the amniotic sac, isn't it? And this is the placenta, the umbilical cord, which is giving the attachment of the placenta to the fetal body. So this is how we are seeing, and these are definitely the layers, the amnion and the chorion, which we are observing here. So mainly this is placenta, amniotic cavity, umbilical cord. The inner one is the amnion and the chorion. And here I would like to emphasize you that amnion is one of the major contributor in the production of amniotic fluid, in addition to the other components that we are going to see later now. So amnion is one of the major contributors for the production of amniotic fluid, in addition to the other components. So in the first and the second trimester, the amount of amniotic fluid is about 5 to 50 ml, and mainly it arises from the ultrafiltrate of the maternal plasma through the vascularized uterine decidua. So what does this explain to us? That it's an ultrafiltrate. It means it's an ultrafiltrate. It has come after the different osmotic or the diffusive processes from the maternal blood vessels, from the maternal plasma through the vascularized uterine decidua, as it is going to supply the placenta, and therefore the amnion and these are all being associated with it. So we are going to get this fluid as an ultrafiltrate of the maternal plasma through the vascularized uterine decidua. Um, Also, transudation of the fetal plasma, transudation of the fetal plasma through the fetal skin and the umbilical cord up to 26 weeks. This is what I want to emphasize to you, that the source of the amniotic fluid in the earlier part of the gestation, let's say like around 20 weeks, it's the fetal plasma, it's the fetal skin, it's the fetal lungs. These are the major sources. As the gestation proceeds further, then comes the amnion, and then definitely the uranus. So this is what we are. These are the sources: fetal plasma, fetal skin, transfusions from them, fetal urine, fetal lungs, and then in the later gestation, the later part of the gestation, from the amnion and the maternal plasma to the uterine vesicle. So it is isoosmolar with the fetal and the maternal plasma. This is very important fact as well, that it is isoosmolar. And the osmolarity is going to be different than what we are going to encounter. Then maybe there will be different other complications which we can encounter of hypoosmolarity or hyperosmolarity. So the nature has rewarded us with an isoosmolar amniotic fluid with the fetal and the maternal plasma. This is how the circulation happens. You see, these are the pathways. This is a uterine wall. You can see these are transmembranous movement, intramembranous skin, placental surface, and the cord surface. From these surfaces, from the placental surface, from the cord surface, and the intramembranous skin, the fluid is being transmutated inside the fetal tissue. This is the flow. This is the flow. And from fetal urination, it is coming out into the amniotic sac. Then expiration and the swallowing of the lung fluid. It is coming inside the fetal tissue to a lesser extent. On the other hand, giving more and more into the amniotic fluid, the lung fluids as well. Similarly, swallowing. The fetus swallowing the fluid inside its body from the amniotic fluid. Please keep these in mind, because many of the other abnormalities which we are going to discuss later in this lecture will revolve around these movements of the amniotic fluid inside the fetal body or outside of it, and then we are going to encompass and encounter different other clinical modalities and clinical pathologies. So please don't forget this. Again, I would like to revise. It seems to be a bit boring at this time, but these have all the clinical relevance. So therefore, please don't forget them. So either the fetus is swallowing the amniotic fluid, the movement of the fluid from the placental surface, cord surface, and intramembranous skin inside the fetal tissue. Fetal urination is giving the fluid outside into the amniotic cavity, and the expiration and swallowing of the lung fluid as well. So these are all happening. Major of the fetal congenital anomalies also revolve around these features, as we are exploring further in this lecture. And here also you see, this is how you can see these arrows. This is the lung fluid. The fetus is exhaling out or expiring out, swallowing inside. You can see, so it means fetal movements, the fetal breathing movements and fetal swallowing movements, and have also a relation with the amniotic fluid. Because we are going to further see in their clinical pathologies we are discussing further. The placenta, then placental tissue movement of the fluid from the amnion and the colon tissue as well. So the amniotic fluid volume, according to the gestations, it is approximately at these gestation we encounter around this much of the amniotic fluid. So you see the circle again. This is the amnion, the yolk, the umbilical cord, and the placenta. And around 10 weeks, we would let's see, we can have about 3 mils, more or less. Around 20 weeks, about 100 mils. 30 weeks, about 600 mils. You see, around 2 trimesters, there is enhancement in the amount of the amniotic fluid in a normal pregnancy. At around 38 weeks, we expect around 1 liter. Now coming to this, around 40 weeks, like when it is becoming post-stated, or around the term, 40 weeks, 42 weeks, you see, it's declining. This is also a very important clinical relevance, so keep this in mind. At the end of the lecture, I would like to review again these slides with the clinical aspect as well, and then you will have, inshallah, a more thorough knowledge with the reference to the other diseases where we are inculcating the amount of the amniotic fluid or the abnormalities of it, and you will have a more clear picture clinically in the clinical orientation. So the physical features. Regarding the physical features, it's alkaline in nature with a pH of about 7.2, with a low specific gravity, and hypotonic to maternal serum at term. And osmolarity is about 250 osmoles, and color is in early pregnancy it is colorless. At term it becomes pale straw colored at term. Mostly we are saying, oh, it looks like an old light. It looks like an old light. It's a layman terminology which we are using. In a normal pregnancy, it should be colorless. If it is blood mix or it's meconium mix, so it has further clinical implications. So how the clinical features, if we say, the clinically it's colorless with slight to moderate turbidity. If it is dark, then it is normal. It's normal. You see, if it is dark or blood streaked, then is it a traumatic stab? We did in cases of polyhydramnios, abdominal trauma has happened, or is a concealed accidental hemorrhage, or in cases of abruption of placenta, it has happened. Even in cases of placenta previa, if there is accompanying abruption, we can have a lighter mixed hemorrhagic discharge as well. So yellow or golden, it is for it is hydropic disease of the newborn, resistant incompatibility it can be, or in cases as we discussed earlier of term or post-term pregnancies. Dark green shows it has a meconium. And what is the meconium? It is the passage of the fetal stool. Mainly it's the passage of fetal stool, and it happens whenever the fetus is in stress in pathological stage, or in case of a normal pregnancy at term, the fetus can pass meconium. So it can be different gradations of the green color, from the light green to darker grading, and the darker the one or the base like it is, we consider if post-term pregnancy is ruled out, that the baby is in fetal distress, and we are in a hurry to plan for the delivery. If it is dark red or brown, there are fetal death or intrauterine fetal demise has occurred, and in the green or shallow color, it's post maturity, as I discussed with you earlier. So this is how the clinical features, the physical features of the amniotic fluid can give us some clinical relevance. I think with just a bit of a slide, just one I am sharing with this one, which I am sharing with you. It has maybe reminded you of, or it has given you a revision of your different previous diseases of obstetric which we have discussed. So how the features of the amniotic fluid can help us for the recognition of these diseases. So it has the amniotic fluid is about 98% of water and 2% of the solid substances. It has organic, non-organic, and suspended particles. So what are the functions of amniotic fluid? It gives the cushions to the fetus from the physical trauma. This is a very important function. It cushions the fetus from the physical trauma in the later gestation, because the uterine cavity, it is a very strong and tough uterine muscle is very tough and strong. It is protecting, and it is holding on a fetus. It should be a stronger thing, and it has given a strong strength to the developing fetus and a strong protection. But the fetus, which is very delicate, it has to be protected as well from this strong contracted uterus. And in that case, the amniotic fluid between the uterine wall and the fetus acts as a cushion and prevents the physical trauma to the fetus, as well as the pressure attached to the uterus. It provides a barrier against infection because amniotic fluid is aseptic. It is aseptic, so it provides a barrier against infection as well, sending infection from the lower genital tract. It permits proper lung development. Why now? This was a thing I was telling you that to understand this, it is very important. You should understand the movement of the amniotic fluid inside and outside the fetal body. As we discussed earlier, that the fetus swallows the amniotic fluid inside, as well as it expires and inhales and exhales the lung fluids also. It inhales as well and exhales. So whenever it inhales it, it is going to expand the lung. It is going to expand the lung. So therefore, a proper movement of the amniotic fluid volume inside and outside the body, and definitely the adequate amount of the amniotic fluid is necessary for the proper lung development. Now you see how important is the function of the amniotic fluid. From this also we gather that in premature fetuses or in the fetuses with oligohydramnios, with a lesser amount of the amniotic fluid, definitely the lung development will be affected. It helps in the thermoregulation for the fetus as well and allow room for the fetal growth, movement and development, as it gives you a bathing place for the fetus. If it is good enough, a good amount of amniotic fluid, and the body of the fetal body is free to move, rotate, kick and flick, so that the definite and appropriate growth can occur. If there is liquor is reduced, it will be like a, sort of prisoner inside the uterine cavity, and it would not be able to grow and move in a required manner. So during labor, the bag of the four waters, the four water is the amount of the amniotic fluid and the bag of the membranes in front of the fetal head in a cephalic presentation, lying over the cervicine cervix. It allows a regular dilatation of the cervix. See how important is its function. After rupture membrane, the amniotic fluid serve as a lubricant for the fetal descent as well. And the color of the liquor, as we discussed in previous slides, also gives us clue for the different clinical pictures. Also, the amniotic fluid is bacteriostatic, as I told you. So, what are the clinical importance about it? It is a screening for the malformation. How? Yes, when we were doing the amniocentesis, this were aware about it. When we were doing about the amniocentesis, the amniotic fluid is withdrawn under ultrasound guidance, and then it can be assessed for different diseases. Assessment of fetal well-being can be done if it is good enough and adequate enough according to gestational age. It has a good predictor for the good fetal development. Assessment of the fetal maturity, as I discussed with you. Diagnosis of the follow-up of labor. Detection of the genital fetal infection by the amniotic fluid which we withdraw, and determination of the fetal age, diagnosis of the premature rupture of membranes if it is obvious on the slides and on the speculum examination, the patient is draining lighter. We come across and we are confirming that the patient has rupture of membranes, and cytogenic analysis as well. Detection of fetal distress as by the when it is meconium stained or it is blood stained, so it can give us a clue about the fetal distress as well. Uh, when we assess the chemical compositions, urine can be scanned for the hemolytic disease of the wall, less than sphingomyelin ratio for the fetal lung maturity, and phosphatidyl glycerol. Also, it's a good predictor for the fetal lung maturity. Creatinine and alpha fetoproteins for the different diseases like Zyme syndrome and for the screening purpose. Neural factors as well. Now, coming to polyhydramnios. It is defined as excessive amount of amniotic fluid, roughly around 2000 mils or more, But specifically we define it as an amniotic fluid index of more than 25 centimeter for the at term, or we define it as more than 95 percentile for the gestational age. This is the definition which is mentioned in your textbooks, that amniotic fluid volume or amniotic fluid index of more than 95 percentile for that gestational age. This is important for that specific gestational age. And then or the deepest vertical pool of more than 8 centimeter. What is the deepest vertical pool? This we are going to assess now. It is 95th or 97th percentile of the gestational age. So in the textbook it is mentioned around 25th. Polyhydramnios is excessive amniotic fluid which is surrounding the fetus. So, so AFI of more than 25 centimeter. And what is the deepest vertical pool? This is the deepest vertical pool is an ultrasound diagnosis when the uterine cavity is arbitrarily divided into four quadrants, and amniotic fluid volume is studied in each pocket devoid of any fetal tissue or umbilical cord, and then the amount of amniotic fluid is studied in it. This is known as the deepest vertical fold. Again, I would like to revise that the uterine cavity is divided into four quadrants arbitrarily, and amniotic fluid volume in each quadrant is studied, and it should be devoid of the umbilical cord and the fetal parts. And if it is more than 8 centimeter, it is about the um, showing the polyhydramnios. So its incidence is about 0.5 to 1%, and 50 to 60% are idiopathic. 20 to 20% neonates are born with a congenital anomaly which have polyhydramnios. And among the congenital anomalies which we encounter can be of gastrointestinal system 40%, around 40%, central nervous system about 26%, cardiovascular system around 22%, and genitourinary system around 13%. Now, how does it happen? This was again, I'm going to tell you that this is also on the basis of the movement of the amniotic fluid inside the body cavity of the fetus, as well as of the amniotic cavity. As we studied earlier, that the fetus swallows as well. Fetus swallows the amniotic fluid. What happens if the fetus is not able to swallow? So the more of the amniotic fluid volume will be accumulated inside the amniotic cavity, and this can happen when the fetus has GI problems. Suppose tracheoesophageal fistula. So in the case of tracheoesophageal fistula, more of the amniotic fluid will be inside the amniotic cavity. The fetus will present with the polyhydramnios. So therefore, polyhydramnios is a symptom which can lead us to investigate the fetus and the mother for the different clinical implications. Always remember this. Polyhydramnios itself is not a disease; it's a symptom which is alarming us to further enhance our clinical knowledge to evaluate the mother and the fetus for the to rule out a certain clinical implication. So the gastrointestinal system such as tracheoesophageal fistula, in these cases, the fetus is not able to swallow. So definitely it is having more and more amniotic fluid into the uterine cavity, amniotic cavity. Then coming to the central nervous system, again we studied that the membranes excrete more and more of the fluid. So in cases of anencephaly or any other central nervous system abnormalities where the membranes are exposed, they're excreting more and more of the fluid, and which is accumulating inside the uterine cavity. So central nervous system abnormalities also can be leading to the polyhydramnios. Cardiovascular system as well, genitourinary if the urinary bladder and the renal systems are affected, and these are more so in cases of oligohydramnios, which we are going to see now. So, how we are going to measure them? Either the amniotic fluid index we are going to see where we, again, as I told you before, that we're dividing the amniotic cavity to the four arbitrary uh, quadrants and then taking their average. Single deepest pocket methods, as I told you, or two diameter fluid pocket. Several factors may modulate the amniotic fluid index, either with increase with higher altitude, where the people are living in the high altitude, maternal hydration, increase amniotic fluid, but it's not confirmatory. Fluid restriction or dehydration decreases, but not confirmatory. These are some of the myths which we have made, and it can be of this aspect that when maternal hydration is improved, it means in a case or so when the fetal circulation is improved, when the placental circulation is improved, keeping in mind that there is no placental pathology. We keep going to give more and more fluid. What's the fun of it until unless there is a normal placental functioning is there, which we are going to discuss further. This is how we are calculating the AFI. You see, we are calculating it in the four quadrants. For AFI, 6 to 8 is borderline AFI around term, and 8 to 25 is the normal one, and more than 25 is the polyhydramnios. So mild hydramnios is around, if you say if the lighter is around 8 to 10 centimeters, moderate 15% is incidence, and it's 12 to 15 centimeter, and severe is around when we say it is 16 centimeter or more. This is how we are calculating. You see, this is a polyhydramnios, the picture of polyhydramnios, more the lighter you are observing, and here is the fetus. So it's more lighter we are observing it, and it is devoid of any fetal part or any umbilical cord. So either it's idiopathic in most of the cases. Maternal causes can be diabetes. Diabetes is a very important cause of um, polyhydramnios. Because diabetes in the mother can lead to, the movement of hyperglycemia in the mother. Glucose is a free passage across the placenta. When more of the glucose tissue enters to the placenta circulation into the fetus is going to secrete more and the more of the insulin as well. It will become macrosomic, as well as it will also develop the features of mother of polydipsia and polyuria. So this polyuria can lead to polyhydramnios. So polyhydramnios in a mother can be a feature of an uncontrolled diabetes in the mother. So in that aspect also we can evaluate that polyhydramnios gives us clue about the mother, how it's control of diabetes as well. So it's not only a feature of maternal diabetes, but it can be a prognostic factor as well. Substance abuse is likely. Most of the substances you abuse like cocaine and so on, they cause oligohydramnios or fetal growth restriction, as we will see further. In isoimmunization, similarly as in the case which happens as in adults, as in cases of severe anemia, same is the case of rhesus immunization in the fetal tissue. The fetus of RH incompatibility mothers, if they are compromised, they will suffer from severe anemia, which can lead to cardiac and failure, and which can lead to fluid accumulation in different serous cavities, and these will also lead to more of the amniotic fluid as well. So for the fetal causes, as I discussed with you earlier also, anencephaly, esophageal atresia, duodenal atresia. Therefore, I told you before that which seems to be boring earlier, they have a clinical relevance. But how is the movement of the amniotic fluid across the fetal body? So definitely a duodenal atresic fetus which has a congenital anomaly of this type would not be able to swallow, and more fluid will be accumulating in the amniotic cavity. Multifetal gestation, definitely TTS, they can also result in polyhydramnios, fetal hydrops in cases of rhesus immunization, fetal echinacea syndrome where the baby is not moving itself, fetal infections. Um, and these are of the lesser importance, and they have of lesser their incidences. And fetal sacrococcygeal teratoma, as in cases of diabetic fetuses, mother of the diabetic fetuses of the diabetic mothers. And here also, because the membranes are exposed at this side of the sacrum, and therefore they excrete more and more of the fluids. Placental hemangiomas, they are also causes of placental causes of polyhydramnios. Acute polyhydramnios is very rare. Usually occurs at around 6 to 20 weeks can happen. And it is associated with monozygotic twinning where we come across with the DTS. And it ends with spontaneous abortion and most of the time before 18 weeks. Severe abdominal pain can be a symptom. Chronic or a long-term history, it happens in gradual in onset around 30 weeks mostly around the pregnancy and can proceed further as well. So about the clinical features, this is where polyhydramnios, how the mother can present to us. Either she is asymptomatic and you come across it only as an incidental finding on your clinical examination or on your ultrasonic evaluation. Or in the other case, the mother can present with dyspnea, edema, abdominal distension, abdominal girth increases rapidly in acute polyhydramnios, and oliguria from ureteric obstruction, preterm labor, heartburn, and indentation, because they all cause pressure effects. Similarly, the pressure effects on the lower limbs can present as varicose veins. And mirror emerges in cases of when they are affected with the blood disorders, the mother is affected with the blood disorders. So on the abdominal examination, which we are going to observe is obvious superficial blood vessels, globular abdomen, abdominal skin appears stretched and shiny. This is very important. Marked stria gravidarum, because there is stretch marks are aggravated because of the effect of the intrauterine pressure. Uterus is dense, increase in physiofundal height, difficult to palpate fetal parts, definitely because the uterus is dense. Fluid swells is maybe positive in cases of severe polyhydramnios and difficult to hear the fetal heart sound as well. And what about the fetal movements? They will be vigorous. They can be vigorous. So what investigations we need to do is full blood count, cord screening we need to do. Uh, we need to have a fasting blood sugar, OGTT, and uric acid, uh, placental biopsy, assess the fetal well-being by ultrasound, CTG, Doppler, and biophysical profiles. This is very important. And excessive amniotic fluid and fetal abnormalities. And definitely our investigations are cause related as well. Our investigations are cause related as well. Where with the history, you have found some of the features from the your investigations will be directed towards your history as well. So the cause of the condition should be determined if possible. Management depends upon the condition of the fetus and the mother and the cause and degree of polyhydramnios which we encounter, stage of the pregnancy, and the fetus compatible with extrauterine life or not. As we have discussed the different causes, so therefore our management is directed towards it. So if the symptomatic polyhydramnios, schedule weekly or twice weekly parental visits depending upon the gestational age or the severity. Hospital admission in case of dyspnea, abdominal pain or difficult ambulation. Serial ultrasonography for the fetal assessment. Antacids to relieve the heartburn. Reduce the amniotic fluid volume, immunosynthesis can be used. Induction of labor if worsening, cord prolapse or the risk of abruption. In cases of term, delivery should be in the hospital, and role of indomethacin, as we will discuss now. So indomethacin is a prostaglandin synthetase inhibitor. It impairs the fetal lung liquid production. It has definitely a role in this part. It enhances its absorption. It increases the fluid movement across the fetal membranes and reduces the fetal urinary production. So these are all the functions which definitely, as they are giving us the impression, they help us in lesser production of the amniotic fluid. But on the other hand, it causes premature closure of the ductus arteriosus. So periventricular leukemia, and therefore it should not be used after 35 weeks. So because the time of the delivery is nearby and we are at risk of fetal premature closure of fetal ductus arteriosus, so we are not going to use it as a remedy after 35 weeks of gestation. Then treat the underlying cause, fetal anemia, TTS, diabetes should be treated accordingly. And what are the further complications? They can be unstable eye, malpresentation, cord prolapse, from placental abruption, premature labor, all because of the pressure effects of the polyhydramnios. High perinatal mortality rate can be there. ureteric obstruction for the mother, postpartum hemorrhage, because the standard uterine cavity has now difficulty to contract. So we can encounter postpartum hemorrhage, and maternal morbidity and mortality can increase. Now coming to oligohydramnios. It is the abnormally small amount of amniotic fluid which is less than around 300 to 500 ml a term, or in according to books, it can be defined as less than 50 percentile for the gestational age. Incidence is around 8 to 30% in the pregnancies, and about more in cases of antenatal patients, around 50% in the post-term patients, around 50% because more of the amniotic fluid gets absorbed at term and post-term. So in about 50% of patients who will encounter oligohydramnios, but it's part of the post-maturity process and can be happen in labor when there is rupture of membranes. So this is how you see. You see, this is normal. By ultrasound, if you see, this is how the normal amniotic fluid seems to be, and how it is the oligohydramnios. You see, all are the fetal tissues or the placental tissues, and this is a smaller bit of a amniotic fluid pocket here you are observing. And on the other hand, you see, this is how a good amount of amniotic fluid you can observe here. So, what's the etiological causes of the possible etiological causes of oligohydramnios? Premature rupture of membranes around 50% in cases. Chromosomal anomalies can be caused. Because the chromosomal anomalies, what were the systems which are producing amniotic fluid? The lungs, the fetal skin, the urinary system, the respiratory, the GI. They were all involved in it. Similarly, novelties of this can lead to oligo as well. Congenital anomalies like in Potter syndrome, intrauterine growth restriction. Why? Why? Because there will be placental abnormality, and placenta and the uterine residua and a good placental blood flow is a predictor for a good amniotic fluid volume for the fetus. On the other hand, if the placenta is diseased, it is pathological in case of hypertensive disorders, in cases of APLS, SLE, then definitely we are going to encounter oligo as well because of the lesser placental profusion, Intrauterine fetal demise, post-term pregnancy. Placental causes abruption, one of the major causes, and TTS, idiopathic, maternal placental insufficiency like preeclampsia. This you have, I know you have learned in more detail about it, that how a placental pathology can affect the amniotic fluid volume. Chronic, known cases of long-term diabetes, not the gestational ones, where the vascularity is affected already. Vascular disease in the mother has already been of greater degree. The drugs like prostaglandin synthetase inhibitors, like indomethacin, if in overdosage it is given, definitely it will lead to oligohydramnios. AC inhibitors are a cause of oligohydramnios because they can affect the fetal renal status as well. Therefore, they are contraindicated even if the patients are chronic hypertensive and they are taking AC inhibitors long before their gestation or they conceived. So it is contraindicated. This is the Potter syndrome. You see the consequences of renal agenesis. In case of, what happens is that it is embryologically, if the mesonephric duct at the ribs they are not they are defective, and we are leading to renal agenesis. There is lack of urine, which leads to pulmonary hyperplasia, death from respiratory insufficiency, fetal compression, because the amniotic fluid is not around it, so there can be prepresentation, fetal malpresentations, humped up uterus, abnormal positioning of the feet and hand, you see, because the uterus has, the amniotic cavity has not good enough amniotic fluid volume for the fetus to grow and have a full development. This was the thing I discussed with you earlier, that how the amniotic fluid volume, good amniotic fluid volume inside the amniotic fluid cavity is helpful in the fetal growth and development. If it is not along with us, then this is the what sort of cases we are observing. Mostly also even in the milder cases of talipes equina virus, we also see, if we go into the retrospective aspect, that we find that the mother had amniotic fluid on the lower side. So the Potter syndrome can lead to pulmonary hyperplasia, oligohydramnios, twisted skin, wrinkly skin, twisted face, Potter facies, extremities with defects, and renal agenesis, bilateral definitely. So this is, you see, even the club fit can occur, enlarged bladder is there, but there is obstruction. there is PUV. It is post-urethral valves. There is a post-urethral valve also. That was the Potter syndrome, which is the anomaly with the major renal system at the time of abnormalities of the mesonephric duct. But if there is only the posterior urethral valve, which can be relieved after delivery or in utero as well, it can also lead to hydronephrosis and decreased amniotic fluid flow. So this is one of an other cause. This is one of an other cause. Small lungs, you see, enlarged kidneys because of the renal backflow, enlarged bladder, club feet. The movement is affected here. This is the club feet. Hydronephrosis is there and decrease in amniotic fluid flow. This is peripheral. So, what are the signs and symptoms? There are no specific symptoms, but they can give a history of vaginal leaking. And in the postpartum pregnancies, we also observe that there is decrease in amniotic fluid volume, chronic hypertensive diseases, in preeclampsia, where the uteroplacental insufficiency is there, as we have studied in hypertensive diseases, that normally the placenta functions as a sponge. It functions as a sponge with a good absorption of the blood coming through the maternal decidua and absorbing from the placenta and through the umbilical cord, giving a good fetal blood supply. In the cases of hypertensive disorders or in cases of severity of preeclampsia, it would act as a brick. It would act as a brick. And the blood, as if it strikes as a water hose, if it strikes a brick wall and then it is repulsed back. Similar is the case in cases of preeclampsia. The blood supply which is coming from the decidua, it would act as a water hose which is striking as a brick wall, and it is being repulsed back, rebound back, and the fetal is devoid of the good fetal circulation and definitely leading to a poor amount of amniotic fluid volume production. So in these cases, decreased AFI would lead us to do a direct questioning to the mother regarding her hypertensive status in her or in her family. There can be less fetal movements. Definitely, if the amniotic fluid volume is less enough, the fetal movements would be restricted. And what are the signs? The uterus is small for dates. It is having a malpresentation can be there. Intrauterine growth restriction can be there. Fetus would also be showing a normal or sometimes a non-reassuring cardiotopography, and small columns or small vertical pools of amniotic fluid volume will be seen on the ultrasound. So the etiology depends upon our what was the etiology. Our management depends upon what's our etiology. Either it's an hypertensive disease or it's a congenital anomaly which is leading to it. So we have to do our management directly towards our etiological factor. What's the gestational age when we are counting? The earlier the oligohydramnios appears, it is more difficult for us, because earlier it appears, it is more directed towards or it is pointing towards a chromosomal anomaly or an earlier onset hypertensive disease or an earlier onset of TTS. So these are all very not reassuring signs for us. What's the severity of oligohydramnios? Fetal status and well-being, and the fetus, what is the chances of fetal survival in the extrauterine life? We have to all assess and then manage accordingly. So we all have also to determine while we are determining the etiology, is the history of rupture of membranes or premature rupture of membranes there? What is the targeted was a targeted ultrasonography for the anomalies done, which is mostly done at a 20-week gestation? And is there history of intrauterine growth restriction, intrauterine fetal demise suspected? Amniocentesis, if the chromosomal anomalies were suspected, was it done or not? As early systemic asymmetric intrauterine growth restriction can be present in cases of chromosomal anomalies. Always remember this. And but in the later cases, as mostly in the cases of hypertensive disorders, which we encounter is the asymmetric IgGR, where there is a brain sparing effect, where the vital organs are being spared. But in the cases of chromosomal anomalies, it is a differentiating point that we encounter an early symmetric IgGR. But on the other hand, in cases of hypertensive disorders, we encounter IgGR in the later part of gestation and with the brain sparing effect. So, installation of the integocaramine may be used while we are investigating to evaluate for the PROM, not used in a common practice. It is mentioned in our um, textbooks, but it is not used in a common practice because this integocaramine is giving the color to the liquor, and if it is draining out with it to the speculum examination or vaginal examination, we are observing it. Then nitrogen yellow paper and the litmus paper test, they are used in the common practice, and they are giving us fruitful research for the confirmation if the patient is leaking or not. When we are doing a speculum examination on the blade, you place the litmus paper or a nitrogen test we are doing, it gives us a clue that is it because it changes the color. Ultrasound scan, definitely the amount of liquor is giving us a clue about it, and we have to then also assess about the fetal blood counts. The OGTT can be done also, especially if it is not in the case of gestational diabetes where we encounter polyhydramnios, but in cases of um, chronic diabetics or the known diabetics before pregnancy, they can present with oligohydramnios with a growth restriction as well in the pregnancy. So, what's the treatment then? Definitely, the treatment is directed to the cause, to the etiology. Uh, but what are the general regimes which we mostly can advise to the patients if the causes, the major causes, the etiological causes are ruled out, like hypertensive disease you have ruled out, the chromosomal anomalies you have ruled out, and even then, idiopathic sort of oligohydramnios is being determined, then adequate rest can help to a bit because it can improve the placental circulation. Amnio infusion by normal saline, it is mentioned in our textbooks but not being done in the common practice. Serial ultrasound scan definitely can help us to monitor the growth, amniotic fluid volume, and the biophysical profile. And why it is helpful? That it is helping us to monitor the growth and also giving us a clue when and where to intervene, where we encounter that the growth is not the one which is optimum, or amniotic fluid volume or the biophysical profile is not no more satisfactory now, we have to intervene. And either we are going to plan for the and assess for the induction of labor or lower segment cesarean section. Um, we have to also evaluate whenever we are planning for the delivery is both in the case of polyhydramnios and oligohydramnios, either the lung maturity has been attained or not, fetal lethal malformation has been ruled out or not, or and the family and the patient and the lady are taken into confidence or not. Fetal jeopardy is always assessed. If there is any severe IgGR, we have to keep in our mind and we have to make the arrangements accordingly. In cases of severe oligohydramnios, especially. So, our treatment is directed according to the cause. This, as I have told you. If it is drug induced, omit the drug. PROM and PROM related problems, they can be dealt with antibiotics, steroids for the fetal immaturity. Induction of the labor is planned accordingly. And as in case I told you before, like the posterior urethral valves, fetal surgery if it is required, in uterine, any procedure be required, or soon after the delivery, if we need to have prompt any surgical assessment like management like in case of polyhydramnios for tracheoesophageal fistula and so on, or any cardiac surgery, whichever it is needed, they should be planned accordingly and timed around the time of delivery. And the planning with the pediatrician and the pediatric surgeons should be done in liaison. So this should all be always kept in mind. Besides amniotic shunt for the posterior urethral valves can be planned in intrauterine procedure as well, and laser photocoagulation for TTS, both in cases for the polyhydramnios and IgGR can be planned. This is how the nerve infusion is done, although it's to a lesser bit now taken out. Practically, they are done to a lesser bit. So, what's the complication of oligohydramnios? There can be uh, miscarriages, prematurity, intrauterine fetal demise, deformities and contractures, pulmonary hypoplasia, malpresentation, and there is increased risk of morbidity, prolonged labor, uterine inertias, because as we discussed, normal amniotic fluid volume is a precursor for a normal labor process to happen, increased operative intervention. So pregnancy outcome in the oligohydramnios with these complications which we can encounter, there can be stillbirth, fetal malformation, fetal acidosis, and neonatal deaths. Pulmonary hyperplasia and oligohydramnios can be important implications. So therefore, the amniotic fluid evaluation allows assessment of the fetal intrauterine environment. This is the very important thing which we should always keep in mind. And potentially invaluable information can be gained from it, and it requires close follow-up and evaluation. Thank you very much for your attention, and hope you have a good knowledge now and your revision regarding both the topics have been done. Thank you very much.